Hello everyone. So now I'll discuss about the hemolytic anemias. So hemolytic anemia means here the destruction of the RBCs are happening in the periphery. So it is just the peripheral destruction of RBCs. Now this hemolytic anemia can be extravascular hemolysis or it can be intravascular hemolysis. First we'll discuss about the extravascular hemolysis. What do you understand by extravascular hemolysis? It means that the destruction of the RBC is happening outside the blood vessels. Okay. Now we'll understand the mechanism. Now this is what I have discussed previously. This is how the RBCs are metabolized once they complete their lifespan of 120 days. Okay. So once they complete their lifespan, there will be some age-dependent changes in the RBC membrane. There will be some age-dependent changes, and this will make the RBCs less deformable. And because they are less deformable, when they try to negotiate from the cords of Billroth, this is the cord of Billroth in spleen. When they try to negotiate from the cord of Billroth to the sinusoids, they will get trapped. And they will be identified the splenic macrophages, which will metabolize the RBC, which will phagocytose the RBC, and it will cause destruction of the RBC. Once the RBC is destroyed, the hemoglobin will come out, and hemoglobin is further metabolized to heme and globin. The globin part will be converted to amino acids that will go to the bloodstream, and the heme component will be further metabolized to bilirubin. This bilirubin will go to the liver, and in liver it will be further metabolized. This is what we have already discussed when I discussed about the fate of senescent RBCs. Okay. Now, what happens in extravascular hemolysis? In extravascular hemolysis, the membrane alterations, there will be some membrane alterations which are pathological. Okay. I told you normally when the RBC completes its lifespan, there will be some membrane alterations which will make it less deformable. But what happens, there are certain pathological conditions like, for example, hereditary spherocytosis. There will be some membrane defects, there will be some pathological membrane defects that can happen even in younger RBCs, Now, because of these alterations in the membrane, the RBC will become less deformable. And when they try to pass through the splenic sinusoids, splenic cords, and then the sinusoid, they will get trapped inside the spleen. And once they are trapped, again the splenic macrophages will come and they will try to engulf and they will phagocytose the RBCs. So what happens normally with the senescent RBC? The exact same process will be exaggerated in extravascular hemolysis. Okay, so there will be increased RBC destruction inside the spleen, so that will cause splenomegaly. Because the function of spleen is increased. There will be phagocyte increase in the phagocytes. I mean, increase in the macrophages, and there will be congestion of the spleen. So there will be splenomegaly. And of course, because of destruction of the RBCs, these patients will develop anemia. And because there is increased destruction of the RBC, there will be increased hemoglobin release, increased metabolism of hemoglobin, that will cause increased bilirubin production. Now, what will happen to this bilirubin? This bilirubin will go to the liver by binding to the albumin, and inside the liver they will have glucuronide conjugation, and after glucuronide conjugation, they will go into the biliary system. Now, in extravascular hemolysis, there is severe increase in the bilirubin. There is excessive production of bilirubin. Now, this much amount of bilirubin cannot be metabolized inside the liver. Okay, so because liver has limited capacity, once the capacity of the liver is exceeded, there will be increased accumulation of unconjugated bilirubins. Okay, so whatever bilirubin we see in the blood, that is unconjugated bilirubin. Okay, so there will be increased unconjugated bilirubin. Now, this will cause jaundice. So this is the classical triad for extravascular hemolysis: anemia, splenomegaly, and jaundice. Okay, so this is the classical triad of extravascular hemolysis. I'll repeat it again. In extravascular hemolysis, what happens? There is some kind of membrane abnormalities or something that will cause the RBCs to become less deformable. Because they are less deformable, when they try to pass through the spleen, because splenic cords of Billroth, and then they try to go to the splenic sinusoids, they will get trapped. Once they get trapped, the splenic macrophages will come and they will phagocytose the RBCs and they will destroy the RBCs. Once the RBC is destroyed, there will be increased production of hemoglobin. There will be increased production of hemoglobin, and hemoglobin is further metabolized inside the spleen, and this will cause increased production of bilirubin. This bilirubin will go to the liver, but once the capacity of the liver exceeded, there will be accumulation of unconjugated bilirubin. Now, all these processes will lead to anemia, splenomegaly, and jaundice. Okay. Now, the next point you have to understand is because there is increased hemoglobin production inside the spleen because of RBC destruction. Now, this hemoglobin, some of them can actually escape from the spleen. Some of them can escape from the spleen and they can go to the blood vessel. So this is the blood vessel. Some of this free hemoglobin, they can go to the blood vessel. The free hemoglobin cannot circulate inside the blood vessel, so they will bind to a protein inside the blood vessel, which is known as haptoglobin. They may also bind to alpha-2 globulin. But for us, the most important one is the haptoglobin. Okay. So free hemoglobin cannot stay. It cannot stay in the blood vessel. So they have to bind to some kind of protein. So they will bind to haptoglobin and they will bind to the alpha-2 globulin. Now this hemoglobin haptoglobin complex. So they will make this hemoglobin haptoglobin complex. Now this complex will again be taken up by the reticuloendothelial system, the macrophages, and they will be metabolized further. I mean, they will be destroyed further inside the macrophages. Okay. So that means in these patients, the haptoglobin will also reduce. We will discuss in the intravascular hemolysis. In intravascular hemolysis, because there is excessive free hemoglobin production inside the vessels, all those free hemoglobin, first they will try to bind to the haptoglobins. So in intravascular hemolysis also, the haptoglobin will also reduce. Okay. So what is the difference? So from this, you can understand that in both extravascular and intravascular hemolysis, haptoglobin will reduce. But the severe reduction in haptoglobin will happen only in the intravascular hemolysis. Okay. Because their free hemoglobin inside the blood vessel is more. In extravascular hemolysis, the free hemoglobin inside the blood vessel is less. Okay. And in intravascular hemolysis, the free hemoglobin inside the blood vessel is more. That's why the haptoglobin reduction is severe in intravascular hemolysis compared to extravascular hemolysis. Okay, so these are the points about extravascular hemolysis, and you have to remember the triad. The triad is anemia, splenomegaly, and jaundice. Okay. Now we'll discuss about the intravascular hemolysis. One more point I forgot to tell. So whenever there is excessive production of bilirubin, this bilirubin, they can actually cause a stone formation inside the gallbladder. These are known as the pigmented gallstones. Pigmented gallstones. So pigmented gallstones and unconjugated hyperbilirubinemia, these are the two features of excessive bilirubin production. Okay, so these are all the features of extravascular hemolysis. Now we'll discuss about the intravascular hemolysis. So the basic difference is in intravascular hemolysis, the hemolysis is happening inside the blood vessel. So there can be various causes. It can be due to some mechanical damage. It can be due to some infections like malaria. It can be due to some toxins. It can be because of some complement deposition on the RBC surface. So all these causes we'll discuss later. So whatever may be the cause, the RBC will get destroyed inside the blood vessels. Okay. Once they are destroyed, there will be generation of free hemoglobin. So this is free hemoglobin. Now I told you the free hemoglobin, it cannot stay alone inside the blood vessel. It has to bind to something. Now it will bind to the haptoglobin. So this is the haptoglobin. It will bind to the haptoglobin. And I told this hemoglobin haptoglobin complex will be taken up by the macrophages in the reticuloendothelial system. And they will cause destruction of this hemoglobin haptoglobin complex. And again, inside the macrophages, this hemoglobin will dissociate into the hemoglobin. Heme will be further metabolized to bilirubin. So there is increased production of bilirubin. And if there is excessive production of this bilirubin, it can cause jaundice. As I told previously, it can cause increased unconjugated hyperbilirubinemia. So that can manifest as jaundice, and you may also get pigment gallstones. Okay, but these features are less compared to what we see in extravascular hemolysis. In extravascular hemolysis, you will find more of jaundice and pigmented gallstones. In intravascular hemolysis, you may get, but it is less compared to the extravascular hemolysis. But what more you will get in intravascular hemolysis? Now, once this free hemoglobin bind to haptoglobin and they are taken up by the macrophages, gradually the haptoglobin levels will reduce, and ultimately there will be no haptoglobin to bind to the free hemoglobin. There will be no haptoglobin to bind to the free hemoglobin. Now, what will happen? Now, this free hemoglobin will be oxidized to met hemoglobin. I have told you previously that the free hemoglobin, they can be oxidized to met hemoglobin, and inside the RBCs we have a protective mechanism, that is the met hemoglobin reductase a pathway which can convert this mid hemoglobin back to the ferrous form of the hemoglobin. Why mid hemoglobin is not desired? Because it has increased oxygen affinity, which will cause left shifting of the oxygen dissociation curve. Okay, so it has increased oxygen affinity. It will cause left shift of the oxygen dissociation curve, and it will cause reduced oxygen delivery to the tissues. That's why mid hemoglobin is not desired. But whenever there is free hemoglobin, it can be converted to mid hemoglobin, and that will give a brown color to the blood. It will give a brown color to the blood. Okay, now inside the blood vessel, we have free hemoglobins and we also have mid hemoglobins. Now, what will happen? Now the blood is filtering through the kidneys. Now, this free hemoglobin and mid hemoglobin will go to the kidneys. But before that, whenever there is increased free hemoglobin inside the blood, that condition is that is referred to as hemoglobinemia. Hemoglobinemia. That is hemoglobinemia. Okay. So now free hemoglobin and mid hemoglobin, they will go to the kidney. They will be filtered through the glomerulus. But again, some of those hemoglobins, they will be reabsorbed in the proximal tubular epithelial cell. So this is proximal tubular epithelial cell. And because they will take up this hemoglobin, they will reabsorb some of these hemoglobins. Now the hemoglobin will go into the proximal tubular epithelial cell, and there it can be destroyed, and so there can be accumulation of iron inside this cells, proximal tubular cells, and this condition is known as renal hemosiderosis. Because iron will get deposited in the form of hemosiderins. Okay, so hemosiderin is an iron containing pigment. It's a iron containing pigment. Whenever there is excessive accumulation of iron, they will get deposited as hemosiderins. So this condition is known as renal hemosiderosis. Okay, so some of the free hemoglobins and mid hemoglobins can be absorbed, but all of them cannot be absorbed. So whatever that cannot be absorbed, it will pass into the urine. So in the urine, what you are going to get? You will get hemoglobinuria. And some of the hemosiderins that are deposited in the proximal tubular cells, those hemosiderins can also come into the urine. So they can also cause hemosideruria. Okay, so these are the features of intravascular hemolysis. So you are going to get hemoglobinemia, you are going to get hemosiderosis, renal hemosiderosis, you will get hemoglobinuria and hemosideruria. So these are the features of intravascular hemolysis, and these features are not seen in extravascular hemolysis. In extravascular hemolysis, you are going to get anemia, sphenomegaly, jaundice, and pigmented gallstones, and sometimes you will get decreased haptoglobin. In intravascular hemolysis, there is severe decrease in haptoglobin, and hemoglobinemia, hemoglobinuria, hemosideruria, and also renal hemosiderosis. You may also get increased bilirubin leading to jaundice and pigmented gallstones, but these features are less compared to extravascular hemolysis. Okay, so these are the basic difference between the extravascular hemolysis and intravascular hemolysis. Now, can you tell me in which of these conditions, both these conditions, you can get iron deficiency anemia? Or you can tell simply iron deficiency. In which of these conditions you are going to get iron deficiency? So basically, in extravascular hemolysis, you are not going to get iron deficiency because here the RBCs are destroyed inside the spleen. It is destroyed inside the spleen, and from this heme, the iron can be dissociated and it can go into the bloodstream. Okay, so macrophages, when they metabolize this heme, it can take up the iron, and that iron can go into the blood vessel again. So there is no iron deficiency in patients with extravascular hemolysis. But in intravascular hemolysis, what you are getting hemoglobinuria. So that means the hemoglobin is getting out in the blood. It is getting out through the urine. Similarly, we are also getting hemosideruria. That means the iron containing pigments or the storage form, they are also going out through the urine. So the iron is being excreted through the urine. So in intravascular hemolysis, you are going to get iron deficiency. But in extravascular hemolysis, you are not going to get iron deficiency. Iron deficiency is usually not seen in extravascular hemolysis. Okay. So now that we have discussed about the intravascular and extravascular hemolysis and the differences, now let us discuss the morphology. Now all these things you can now tell as we have discussed all the basics. So what you are going to get in peripheral blood, because there is peripheral destruction of RBCs, the bone marrow will start to increase the erythropoiesis. It will try to increase the erythropoiesis in response to erythropoietin. So because of increased erythropoiesis, you are going to get increased reticulocytosis in the peripheral blood. So you will get reticulocytosis. So there will be increased reticulocytes in the peripheral blood. And I have told you previously, reticulocytes can be identified by the presence of chromatins, which you can easily identify on the supravital strains like new methylene blue or brilliant trestle blue, or maybe crystal violet. What you're going to get in bone marrow? So bone marrow, there will be increased erythropoiesis. Increased erythropoiesis means there will be increased immature erythrocytic precursors. Increased immature erythrocytic precursors. So this immature precursors, these are known as the normoblasts. So you will get increased normoblasts or erythrocytic precursors. So increased normoblasts. As you can see in this picture, this is a bone marrow aspirate picture. You can see these are all the erythroblasts or the normoblasts. You can appreciate they have a blue cytoplasm, basophilic cytoplasm, and they have a chromatin which is slightly opened up. It's a large nucleus and slightly opened up chromatin. So these are all the erythroids. These are all the erythroids. What you're going to get in liver, spleen, and bone marrow. So in all these places, there will be destruction of the RBCs. So you will get hemosiderosis. Hemosiderosis. That is the iron will get deposited in all these places, and you are going to get hemosiderin. Kidney also, I told there will be increased hemosiderin. There will be increased hemosiderin, but it is usually found in intravascular hemolysis cases, not in extravascular hemolysis. In gallbladder, I told you you will get pigment gallstones. Okay, and sometimes if there is excessive hemolysis, and the bone marrow is not able to compensate for the loss of RBCs, there can be extramedullary hematopoiesis. It can be extramedullary hematopoiesis, and extramedullary hematopoiesis usually happens in liver, spleen, and sometimes in lymph node also. Okay, so that's all about the basics of hemolytic anemias. And in the next section, we'll discuss about the hereditary spherocytosis.